on?
Yeah, hi.
Thank you for the opportunity to present on this august occasion. It's a privilege. So our case is on the importance of gender and race of patients that present with chest pain to the hospital. Um, so normally, patients coming to the hospital with chest pain usually present with typical pain that are very suggestive of whether heart related or other part of the body. Um, and as doctors, we usually use um, like cardiac markers such as troponin and echocardiogram, i.e. ECG, to determine if the patient will require any acute intervention. However, patients with normal ECG, even though they might have elevated cardiac markers such as troponin, it becomes a challenge to really know what is going on with such patients. So we present a case of a female who came in with persistent chest pain and elevated cardiac marker troponin with a normal echocardiogram, and was later found to have what we call spontaneous coronary artery dissection, SCAD, and then later on was found to have fibromuscular dysplasia. So the patient is a 56-year-old African-American woman, history of high blood pressure, heart failure with preserved ejection fraction, chronic bronchitis, who presented to the emergency department with persistent left-sided chest pain. Initially, the pain was only with exertion, but later on, the pain was even present at rest. Upon further questioning, the patient had chest tightness and shortness of breath. On our evaluation, patient really appeared anxious. Vitals were pretty stable, except that the patient has high blood pressure. The blood pressure was a little bit elevated. Labs were pertinent for troponin with a peak of 5.65 ng per ml and lactic acid of 3.2 millimole per liters. So we did immediately we did an echocardiogram ECG that showed no acute abnormality that was kind of like not expected given the patient presentation. But yeah, the patient didn't have anything acutely on the ECG. We were kind of curious what was going on, so we went ahead to get a CT of the chest, a pulmonary embolism protocol, and that did not show any emboli in the lungs. We also did a transthoracic echocardiogram with ultrasound of the heart that did not show any abnormality either. So presumably, we initiated the patient on some treatment for non-ST elevation MI with some heparin and some other medications that we use for such patient. However, the patient continued to have persistent pain and did not have any relief at all after aggressive anti-angina medication. So the patient was rushed to the cardiac lab for left heart cath, which did not really reveal anything in the the right coronary artery, and not even in the left coronary artery, except for something that was found on the obtuse margina, the long proximal to the distal segment of the obtuse margina. There was a very significant dissection Let me see if I can show it right here for the audience to see right here. A very significant dissection of the obtuse margina. So, and the left heart catheterization did not really find any clots in the arteries. So we did not do any stenting or put any stent, but we went ahead and medically managed this patient with, most importantly, blood pressure medication, which is also a risk factor for, increasing pain in such patient. We were just, again, wondering, being a female with that age and coming in with such dissection, we wanted to find out what other comorbid conditions this patient might have. So we got a CT abdomen and pelvis that found that the patient had this classic strange of beads in the renal artery right here. Okay, and that was consistent with fibromuscular dysplasia. So again, the patient was discharged home on aggressive blood pressure medication, and a follow-up on this patient showed the patient was doing well on home medication. So as a discussion, the first case of SCAD was diagnosed by autopsy in 1991. The prevalence of SCAD is still quite low, even though uncertain. Some studies have suggested about 1 to 4% in all acute coronary syndrome presentations. Even though fibromuscular dysplasia is very uncommon, with female presenting with chest pain and such angiographically suggestive dissection, it is something that you need, as clinicians, we need to look into. It has a female predilection of about 9-to-1 ratio, that is of women over men, and usually you don't really see the classic strength of these in the heart as is found in the renal arteries, but at least you're likely to see dissection as it is in this our patient. It is worth mentioning that other predisposing factors for SCAD, apart from FMD, is autoimmune and connective tissue disorders, peripartum periods, heavy exercise, and certain drugs like cocaine. The management of SCAD is kind of challenging, especially when diagnoses are not clear. However, an approach to management usually stems from a conservative approach like blood pressure medication, making sure the patient is in a relaxing mood to bypass grafting. And sometimes few patients have been stented to that effect. It is very necessary that prompt diagnosis is initiated for such patient, and sometimes it will help these patients to also benefit from other treatment for comorbid conditions like hypertension, as was found in this patient. So in conclusion, I would say that the possibility of SCAD is right on our nose, and is incumbent on clinicians to to factor in such diagnosis for patients who are coming in with chest pain, with no digestive finding on EKG. The early recognition diagnosis is key, given the high mortality rate of such condition. Thank you so much.